Welcome everybody. Welcome to DeBakey CV Live. This is Dr. Randall Wolf. I'm with the DeBakey group here in Houston, Texas, December 1st, 2020. We're going to talk about atrial fibrillation. This is a live webcast. I'll introduce my guest in a minute. Before that, for those of you that would like to interact with us, this is a wonderful time for you to ask a question. If you have a smartphone, you go to Messages, that little icon at the bottom of your smartphone that says Messages. Tap on that and then hit New Message, and put in this number, 37607, and we'll show that on the screen from time to time, 37607. And then under the text box, put in DeBakey. Hit send, and it will show you that you're hooked up and you can send a message, a question. Any question you have, we'll get, and the team will get it to me. So again, if you have a smartphone, go to your messages, hit the button for a new message, and you want to put in 37607, and then in the message, you send it to 37607. In the message, type DeBakey, hit send, and you'll be set up and you can ask us a question on the phone. If you're on your computer and you prefer that, you can go to the website pollev.com, POLLEV.com, put in DeBakey, and just respond to the activity. So you can type in from your computer a question, or you can use your smartphone, join by text. You want to go 37607 and type in DeBakey and send the message. So, atrial fibrillation is a hot topic for anybody who watches TV. There are a lot of ads about blood thinners and the new blood thinners, such as Eliquis. There are ads about a device that can go inside the left atrial appendage called the Watchman device, which, by the way, we can talk about a little bit if you prefer. We also want to talk about how do you, as an AFib patient, decide what to do, and then what are the results. So if you have atrial fibrillation, if you're looking for answers and you have questions, this is a good hour, and we will help you. As I've said before, the internet is full of information, but that's what it is. It's information. Knowledge is actually not that easy to find on the internet. You've got to really look hard to find the knowledge. Lots of information, but where's the knowledge? And even harder to find on the internet is where's the wisdom? An old joke says, what's the difference between knowledge and wisdom? Well, knowledge is knowing that a tomato is a fruit, not a vegetable. Wisdom is knowing tomatoes don't go in a fruit salad. So it's hard to find wisdom on the internet. We hope to present to you some knowledge and some wisdom in this hour. I was talking to a patient of mine, Kuelz, last name pronounced like the Indianapolis Colts, but not spelled that way. And Kurt explained to me how he went through the process of deciding how to evaluate AFib after he had AFib, and then what he ultimately did. And I worked with Kurt, it's been 4 years now, so I thought that would be a good perspective to look at. And as a teaser, next month we're going to talk to a patient who had a Minimaze 14 years ago and still has no AFib. But back to today. Kurt's been kind enough to join us today, tell his story, share it with you, the audience, and also take questions. So one last time, if you're on the smartphone, go to Messages, New Message, put 37607 in the message box, text message box, put DeBakey, and send it, and you can join us with your questions. Kurt, again, I want to thank you on behalf of DeBakey and all the people who have questions about AFib for joining us today. I really appreciate it. You're definitely paying it back. If you don't mind, tell us a little background about yourself and what happened to you. Welcome to the program.
Thank you, Dr. Wolf. It's it's my honor to be here, and I'm just hopeful that perhaps my story can help somebody out there, because I'm forever grateful for the improvement in my life that you provided. So I'm 56 years old. I'm the Senior Vice President for Global Services at a software company called Siemens Digital Industry Software. I'm a husband of 32 years. I'm a father of 2 great kids. And sometime about 4 years ago, well, let's go back a little bit before that. I've always been athletically inclined, always kept myself in good physical condition. And I knew things would change when I turned 50. But it seemed around that time, it went from where I could, go for a run for 3 miles, and that was fine. And then I would struggle to run a mile. And I just thought, okay, I'm getting old, and I hadn't been staying in great shape and working too much. And I figured I'd work my way out of it. I had my Fitbit, and my Fitbit sort of was telling me my resting heart rate was, 100, which I thought, this is kind of odd, and must be reading the data wrong or something like that. And it sort of prompted me to go get a physical. And, they I guess did the, cardiogram or whatever that's called, and told me, okay, it looks like I'm having an abnormal heart rate, right? Which was a little bit concerning, but, I didn't think too much of it at the time. And so they sent me to a cardiologist. I went and visited the cardiologist, and, he did his tests, and he said, yes, I can confirm that you have a condition that's called AFib, or atrial fibrillation, which I had never heard of. I had no clue what it was. At the time, he said, hey, this is a pretty serious condition. You're going to need to, probably going to be a change to your life. You're probably going to need to be on blood thinners for maybe the rest of your life. And, there's some procedures out there that, around this kind of topic of ablation that sometimes are successful. And, it's something you need to look into, right? And start to evaluate. And, so that was pretty shocking. I don't really like to take medicine. I'm not a big pharmaceutical guy. And so the whole idea of being on blood thinners for the rest of my life was just not interesting. I just struggled with that concept. As I learned more, I realized I had already moved into what's called permanent AFib. And there's different stages of AFib. I don't remember all the names anymore. Dr. Wolf could certainly describe those for you, but some of you out there and some people in the world are in and out of this condition. Their heart goes into arrhythmia, and then it comes back into normal, and then goes in and out, and so forth. For me, I had already advanced to the stage of being permanent arrhythmia. Honestly, never knew I had it, so I obviously wasn't very in touch with, my body at some level, at least around my heart anyway. But that was the condition that I had. And when you have permanent AFib, it's even higher, it's even more unlikely that, some of these kind of ablation-centric procedures are what, are going to work, right? And so I continued to see the cardiologist. They tried to shock me out of it. I can't remember the name of that procedure, cardioversion, I think it's called. Yep. They basically shock your heart. I went back into rhythm. That lasted like 3 days, and I came out of rhythm. And for the first time is actually when I felt AFib. When I came out of rhythm, at that point, I said, oh, I knew immediately, like, okay, I'm back in arrhythmia, and this one didn't work. And so you go and you start to investigate more, and there's a procedure where they can insert some device, in your leg and take it up to your heart and start kind of burning aspects of your heart in the hope that, that is going to find the area that's causing the circuitry problem, which causes your heart to not beat properly. And, everything I learned about it is probably less than 30% likelihood that's going to work. And kind of, if it doesn't work the first time, they try it again. If it doesn't work the second time, they try it again. And, after the third time, so be it. You burnt your heart a lot. And and you're still an AFib.
Remember,
It inspired
let me
me.
interject here just for a second, Kurt. For our audience members, it is true that the hardest type of AFib to treat, to get back in rhythm, is when the heart is continuously out of rhythm. And some people say the only distinction we should make is whether the AFib is intermittent or continuous. And Kurt was in the continuous group. Most of the times when you see reports of catheter ablation, they are doing the catheter ablation on people that have intermittent AFib. And that's the easiest type to take care of. The results with catheter ablation with continuous AFib are not good. And as Kurt mentioned, probably 30 chances out of 100 of anything working, even with multiple attempts. The way I have looked at it is that this probably is not a heart problem. Kurt had a normal heart. As he mentioned, he's an athletic guy, healthy guy, works out. I don't think there's anything wrong with the heart when AFib starts. I think it's a nerve problem, and the nerves are outside the heart. So it doesn't make sense to burn heart tissue, destroy heart tissue, because once that's destroyed, it never comes back the rest of your life. And if it's really a nerve problem and the nerve's on the outside of the heart, part of the focus, I believe, in the treatment of AFib should focus on the origin, which is probably the nerves. So that's one of the reasons that I take a little bit different route to treatment of AFib. Just for the sake of completeness, you may hear the word paroxysmal AFib, that's intermittent AFib. You may hear the word persistent AFib, which is intermittent AFib, but sometimes it lasts more than 7 days, or you've had to have a cardioversion or a shock, as Kurt mentioned. That's persistent. That means it's a little more advanced. And then the last kind is what Kurt said, the permanent or the long-standing persistent. That's where you can't get out of AFib, or you've been in continuous AFib for more than 12 months or a year. But maybe the easiest thing to remember is your AFib continuous, you're out of rhythm all the time, or is it intermittent? And then an important part of the history is, if you are continuous, how long have you been continuous? And I think in your situation, Kurt, was it maybe a year when I saw you, or less?
No, it had been longer. I'm convinced that it had been longer than a year. I'm
Okay.
convinced that it'd probably be in multiple years at that point.
Okay.
It just had taken me a while to figure it out.
So in summary, up to this point, you got a healthy, you said you were about 50 at the time, or?
Yeah, 50.
50.
Yes.
Works out, good shape. Really only new problem is AFib, and now you got to, and you're in it continuously, and you're given these, you're given no good news. You're not given much hope. In fact, you're not given any hope. You're told, number one, as you said, you got to stay on blood thinners the rest of your life. 2, you can go for these procedures. So that's when your mind kicks in and says, okay, this is a real challenge. How the heck am I going to beat this? And I think I'll let you go from there.
That's exactly it. So, and I'm an engineer, so I started to, dig into this problem and do research. And I think you mentioned, knowledge and wisdom. And I found lots of information on the internet, but it was all biased around, AFib, and here's the answer to AFib. And they were largely marketing websites. The one shout out I would like to give a huge shout out to is, there's an organization out there, and I want to get the name right here. It's called stopafib.org. And it's run by a wonderful lady named Melanie True Hills. And it was a wealth of information, unbiased, providing a variety of, ways to learn about AFib and procedures. And turns out that when I found them finally, which was just through searching, they were holding a conference. And the conference was I think it was in Dallas. And I wanted to determine my course of action. So it was a 2.5 day conference. I booked a plane flight. I flew to that conference, and I spent the 2.5 days, listening to seminars and going through show and tells. And I would say I watched, doctor after doctor stand up and present, and I must have been 10 of them, and they presented, their approaches to addressing this problem. And honestly, they never spoke to the audience really. They spoke to the audience as if we were doctors. I mean, the language and the terminology and the approaches and the studies and everything they were presenting was, interesting data. It was, I learned a lot. But, near the end of that conference, Dr. Wolf stepped up and he started to talk to us like human beings, like people. And he related to us with words that weren't going all over our head. And he was clear and concise, and he had an approach, and it was easy to understand, and the results were extremely positive. I'll let you quote your success rate, but I remember, numbers in the 90s. And, at that moment, it was obvious to me, like the only clear answer here was to pursue, a Minimaze procedure with Dr. Wolf. It was a bunch of noise and then an obvious answer. And, there was other people at my table. There was another gentleman there, Craig, and we met at the conference, and he was in the exact same situation as me. And I looked at him and he looked at me, and we said, listen, this is the obvious procedure to go to. Because what Dr. Wolf was offering us was to return us to our life. No blood thinners. He can tell you kind of why that's the case. And, to get your heart back in rhythm with a high likelihood, like 90% kind of likelihood that's going to work for you. And even as someone in as severe a condition as mine. So I left that conference. I reached out to Dr. Wolf's office. The whole, the onboarding procedure was awesome. It was easy to go through the procedure, to get scheduled, to get insurance approvals for it, get it scheduled. I flew to Houston. It was like, I think I remember it was like a 3-day event. Dr. Wolf treated me like royalty. I mean, I was like a first class treatment during the whole procedure. The operation went fabulous. I mean, there's a recovery period and it's an operation. So, I mean, you're going to be, but I was only in the hospital for like, I think 2 days after that, or a day and a half or something like that. I flew back to Charlotte. I live in Charlotte, North Carolina, 2 days later. And, since that day, I've never had one instance of arrhythmia since the surgery. I don't take any blood thinners. I returned back to my sports. I'm very, very active. I coach a youth ultimate Frisbee team. I still play some basketball. I go running. I do yoga. I have been returned to a normal life for all practical purposes. If my little monitor in my chest hadn't battery gone dead, I probably wouldn't even know that. Remember, I have AFib, right? I mean, I need to get that taken care of, and that's a little simple procedure. But I am forever grateful, really, of having the last 4 years and what I expect to be future many years of kind of a normal life. And that's why I'm happy to be on this show. And I'd be happy to answer any questions that anybody out there has, because the path for me was obvious. And if you're anywhere near my situation, I would suggest to you your path, it should be equally as obvious. I could not provide you a stronger endorsement for an approach to address AFib than to work with Dr. Wolf. It's just been great for me. And like I said, I'm forever thankful.
Well, thank you, Kurt. We do want to take some questions, and we'll take one question. And I'll remind everybody, if you have a smartphone, go to your messages, hit the little icon where it says new message. At the top, put in 37607. That's where you're going to send it. In the text message, put DeBakey, hit the send button, and you'll be able to ask your question. Let's take the first question now. The question is, how many different types of AFib are there, and do all require intervention? Well, we talked a little bit about the different types, but the main distinction is whether it's continuous, which means all the time out of rhythm, or is it intermittent, means some days you're in rhythm, some days you're not. And then also important in the history is how long if you're out of rhythm all the time, how long have you been out all the time? The other thing that I look at is the echocardiogram, because the longer the heart is out of rhythm, the more enlarged the left atrium becomes. And in my experience, once the left atrium is greater than 5.5 centimeters, the chances of success start going down for staying in rhythm. However, there's still another advantage of the Minimaze, and that is we close the left atrial appendage, the little ear on the heart. So even if the heart stays out of rhythm, with that appendage closed, it's not necessary to take blood thinners anymore. So as most physicians will tell their patients, you have AFib, you're going to have to take blood thinners the rest of your life, which I think Kurt mentioned as well. That's not true. There is hope out there. If the appendage is closed, you don't have to take the blood thinners. And here's a little bit of information that you might find surprising. The newer blood thinners like Eliquis and Xarelto decrease the risk of AFib stroke by 60%. Not that great. I think a lot of people think it's 100%. It's not. However, if the left atrial appendage is closed, it decreases the chances of an AFib stroke by 97%, and you don't have to take blood thinners anymore. So for some patients who've been out of rhythm for 20 years continuously, the left atrial appendage is greater than 5.5 centimeters, I simply close the left atrial appendage so they don't have to take blood thinner life. And as an anecdotal story, I saw an AFib sufferer several years ago, and he listened to the options. I saw him in the office. I told him he could stay on medication, have catheter ablation, or the Minimaze. He was a candidate for all three. He opted to stay on medication, which is primarily blood thinner and something to slow the heart rate. Well, this past year he came back to see me. This is 3 years. 3 years has gone by. And he came back to see me in the office. And I said, I remember seeing you 3 years ago. Have you changed your mind? He said, yes, I want to have the Minimaze. I said, what changed your mind? He had a ball cap on, Kurt. He takes the ball cap off, and you can see where he had a craniotomy. He had emergency neurosurgery operation because he was up on the ladder. He was taking his blood thinner. He slipped, fell off the ladder, hit his head. Because he was on the blood thinner, he bled into his head. He had a stroke and had to have emergency surgery. And he said, I don't want the blood thinner anymore, which is a pretty, dramatic illustration of what can happen if you have to stay on blood thinners the rest of your life. So there is some advantage of getting off the blood thinner. Now, as far as when should you be treated, a catheter ablation or a Minimaze is a reasonable treatment for all the different types of AFib. However, the longer the AFib has been there continuously, the less likely the catheter ablation is going to work, as Kurt said, but the Minimaze may still work if the left atrium is less than 5.5 centimeters. Let's take a question for Kurt. Kurt, how did you feel? What were you thinking when you knew you had to do something about your AFib?
Yeah, I mean, I got to tell you, there was a period where you just you're thrown out of sorts, right? I mean, you're going about your life, and then all of a sudden, you have something, and you've been healthy your whole life. I mean, at least I had been, and now you're looking at a very different life in the future. It was pretty tough. I mean, and I guess me being a problem solver at that point, I needed to find my own way. I needed to come to a conclusion that I was satisfied with. I feel like, I would say this to anybody, you should be your own evangelist. Do your own research. There's enough information out there. And if you do it in detail, I think you'll reach the right conclusions for yourself. And so I set about doing that work. And like I said, the stopafib.org site was, full of information. And I read through all of that. And then the conference was my opportunity to go in there and really evaluate all these different procedures that Dr. Wolf has just spoken about and choose my own course of action. And I'm really happy with the course of action that I chose. But it was a rough period. I mean, I would say there was a 6-month period there where I was just sort of wondering, this concept of being on blood thinners. I mean, the doctors sort of make it seem like, it's okay. It's like a vitamin. No, I don't want to. It seemed like it was presented to me in ways that didn't fully express the risks and the concerns and the cost and the implications of, taking blood thinners every day for the rest of your life. I just was entirely uncomfortable with that concept. So, I mean, for anybody in this position, I would try to pursue a strategy that does not force you to be on blood thinners forever. I just don't see that being a good path forward. But anyway, the short answer to your question is it was very concerning. It was a shock, and I had to find my way through it.
It was a shock literally and figuratively, right?
Yeah, that's true.
Well, here's what I don't understand as a physician. A lot of people who are newly diagnosed with AFib are not given any hope. And what you want as a patient, well, what you want in life in general is you want hope and you want happiness. And half of happiness is having hope. So you go to a physician and gives you a new diagnosis, they don't give you any hope. Well, what's that? And when there are options. So I wish the physicians were more inclusive and presented to their patients all the options so that they would see maybe there's some hope. But you didn't say it, but I guess when you were evaluated, you weren't really given all the options for treatment. Is that true?
It's very true. I mean, I have to say I was extremely disappointed at some level in the profession, because the only thing that was presented to me was the procedures that particular doctor could do. It wasn't like a all-inclusive discussion around, this path or this path. No one ever mentioned the concept of a Minimaze. Had I not gone to this conference, I'm not sure I would have ever found you. And I probably would have pursued, this, catheter ablation approach. And I probably today would be sitting here after taking my blood thinners in the morning and would still be in I would be in arrhythmia. I don't think that I would have come out of it. My heart was pretty persistent, I guess is the term.
Well, yeah, if the cardioversion doesn't work, then that gives you an idea where you're at.
Yeah.
We got, again, for those of you who are getting some good questions, please join us. You can pick up your smartphone, go to messages, hit new message icon, and at the top, put in 37607, and then in the little box where you type in your text message, put DeBakey, hit send, and you can then, you're able to send us a question. Let's take another question for Kurt. This is similar to the last question, but maybe you can say a little bit more. Any words of wisdom, encouragement for someone who is thinking about the procedure? You covered this somewhat already, but any other thoughts on that?
I mean, I would just have faith in this procedure. I mean, I think if you sort of, in the world we're in today where everybody's talking about science and so forth, I mean, rely on the science. I mean, the data that Dr. Wolf has is pretty compelling. The outcome on the other side is so much better, right? And so, whether was the procedure, easy? No, it was not. Did I suffer some pain? Sure. I mean, like nothing worthwhile is really easy. But my recovery wasn't hard. It took a few months. I mean, I was back in work, 3 or 4 days later. I don't work a physically strenuous job, so I work a desk job or I travel a little bit, so that was okay. But I still felt some pain in my chest for months, but I mean, it was certainly live withable. And then today I feel nothing. And I guess I would just, here's what I would say is do your research, pick your direction, and then commit yourself to it and see it through. Right? I mean, I think that's the best advice that I can probably provide to you is once you get started down that path, commit to it, see it through, give it its chance. Don't look back, right? Because,
now, Kurt,
you got to choose the path that works best for you.
One thing you mentioned we ought to talk about a little bit is the LINQ, L-I-N-Q. This is also called an implantable loop recorder. And what it does, it's not a pacemaker. It is a small device which records the EKG continuously. It can store up to 30 days of EKG. But what it does generally every night, about 4 in the morning, it looks for either your smartphone, excuse me, or a bedside device, and downloads that device. That device then uploads to the nearest cell tower and sends me the information. So for the last over 3 years, I was able to follow Kurt in Charlotte, North Carolina, without him ever coming to Houston. You want to talk about that? I guess it gave you some peace of mind, didn't it?
Yeah, I mean, I would, get regular updates on that. And it's how I know I've never had an instance of arrhythmia since. I mean, I have a Fitbit and I'm much more attuned to my heart rate now, but the thing phones home every night. There's a track record of, kind of my heart rate. It's nice to know that you're, not seeing any sort of trend that, I'm falling back into AFib. It's a comforting scenario. And it's like I travel a lot. Well, before the pandemic, I was a business traveler. I traveled, 3 times, 4 times a month, international often. Never had any problem going through the x-ray machines. I've done an MRI because I have a little bit of lower back pain that I was trying to get sorted out. I went through an MRI for that, didn't have any issues with it there. So it's entirely been a non-issue for me as far as having that link device implanted. But it is a nice comfort to know that they're monitoring your heart rate and they're going to reach out to you if you have any issues.
Another question we'll take, is there a device implanted for the Minimaze? Well, the answer used to be no, but several years ago I started, instead of stapling the appendage, I started putting a clip on the appendage. And then for a while it was kind of 50-50. Some patients I would put a clip on the appendage to close it. It's sort of like a giant hair clip. And then some patients I would still staple it and remove it. And I believe, Kurt, you told me that yours was stapled and removed.
Yes.
They both work the same. The clip device is a little bit easier to use. It's a little bit faster, but it is a device. Now it's much like the link. It's made of titanium, so there's no iron in it. If there is no iron in the device, you can still have an MRI, just as you mentioned, and you can still go through security with no problem. So both these devices, the link and the AtriClip, or the clip for the appendage, are titanium. Now, most of my patients, I put a link in afterwards. 4 years ago, I might have done it at the same time. I don't remember for your case.
Same time.
Did it at the same time. A lot of times now I put it in about a week later in the office. It's a 15-minute procedure under local anesthetic where we numb up a little area to the left of the breastbone, and then it's really a special syringe that shoots the device under the skin. And that way, no matter where Kurt is, he can I get his information, so he doesn't have to go to the ER, he doesn't have to see his doctor. If he ever has a question, he can just say, hey, what are you seeing on the link? And plus, the link calculates the percent of AFib per month. So it could say you're out of rhythm 2% or 3% or 20%. Yours is 0.0%, which I think is also pretty nice to know,
Yeah,
and so that way you have this sense that what you're doing is working. And I imagine if you're working out more and you're worried if it's going to put you into AFib, but the link's in there and there's no AFib, it gives you peace of mind. Is that fair enough?
It is fair. I mean,
go ahead.
I was just going to say, I mean, as a testament to that, I mean, the battery does have a life period to it, and my battery's running out, and I'm going to get it renewed, right? So I'd like to keep the link in. To your point, if I would believe that if I trend again, I'm going to have a trend, and I think if you can get in front of it early and see it coming, it's probably easier to resolve than waiting like I did last time, right? Until I was.
Well, you're right. And even though next month I'm having somebody on who had a Minimaze 14 years ago and has 0.0% AFib, not everybody's like that. And every year there's 1 or 2 people that have a recurrence of the AFib. And this is amazing. What we found is, and this could be 10, 12 years after a Minimaze, if we go back through the groin, I mean, we've never had to repeat a Minimaze. If we go back through the groin, we can usually find the spot very easily, some new spot, zap it, and we're done. You don't have to worry about the pulmonary veins. You don't have to worry about the left atrial appendage. You don't have to worry about blood clots. You just go in there, find that new spot, zap it. Everybody that I've had go back for a catheter ablation is in rhythm. So it's extremely successful as a touch-up procedure, an ablation is, many years after a Minimaze, which is also a nice thing to know. And to your point, if you know that before you're continuously out of rhythm for a long time, yeah, it's going to be better for sure. Let's take another question. Again, if you have a question for us, smartphone, I know I'm getting tired of saying this, but it's important because it's confusing. Go to text messages, new text message. At the top where you're sending it, you put in the number 37607, and then in the text message box, put DeBakey, hit the button, you'll be with us, and you can send us a message, a question online. Dr. Wolf, Michael Williams here. Do you implant the link device in all your Minimaze patients? Good question. The answer is no, but the answer is over 90%. Some patients already have a pacemaker, and I saw a lady today who has a pacemaker in place, and the pacemaker gives the same information as the link. Generally, it's not available straight up on the internet, but because most pacemakers are interrogated every 3 months. But I usually don't put a link in if they already have a pacemaker, because we can still get that sort of information from the pacemaker. And every once in a while, there's someone who can't have a link. A good example is a patient of mine from a few years ago who worked for an organization that doesn't allow anybody to have an implanted device, which you come upon from time to time, a government agency. So there are exceptions to the rule, but I would say over 90% of the patients have a link, and everybody's pretty happy with it, and I am too, because the only way for me to really know exactly what the results are to look at follow-up, and that's something that surgeons in general are not very good at. If you've ever had surgeries, you may not even remember your surgeon's name, and when you went back to see your surgeon, you were seen by a nurse practitioner or a PA. But the way to get results is to follow a patient longitudinally. And I follow patients longitudinally by the link. And in fact, we're working on a manuscript right now with medical students from Texas A&M. And this is a really interesting collaboration because Methodist is hooked up with Texas A&M with their new medical school, which is called NMed. You probably never heard of that, Kurt. I might have mentioned it to you before, but you have to have an engineering degree undergraduate to get into this medical school. And I don't think there's any other medical school like that in the world. But these students are great, they're very bright, and they're looking back at the links over the last 3 or 4 years to give us the absolute objective numbers on what the recurrence rate is with AFib. And we're going to do something that very few people have done. The link tells you the percent of time you're in rhythm per month. And we're going to look at that because I imagine if somebody's in rhythm 98% of the time, and before the Minimaze they were out all the time, that's probably good enough. So that's what we're looking at. Look forward to that. Hopefully that manuscript will be out within the next few months. So I think link's very important. As far as I know, not very many people use it post-operatively. That includes electrophysiologists. But why wouldn't you? You really want to know. We talked about, I know what I wanted to show. Could we do a screen share here for a minute of my screen, gentlemen? I got a call from an 80-year-old gentleman a couple months ago, and he said he saw the stopafib.org meeting, which, by the way, is online now. and it was a virtual meeting this year. And you can listen to all the talks that Kurt discussed if you go to stopafib.org, and you can download the 2020 meeting. And he said, I listened to the stopafib.org, I heard your lecture, and you're the only one who said exactly what I was looking for. And he said it was on your first slide. It was stop blood thinners, eliminate strokes, get in rhythm. He said that's what patients are looking for, and you were the first one to clearly state what I'm looking for. So we can go back to the visual. I also, a couple weeks ago, took care of a 83-year-old gentleman from Kentucky. And he had his Minimaze on Tuesday. I have a picture on my phone with the gentleman on Thursday evening at one of the local restaurants where he took me out to eat. So he's 83 years old. He has his Minimaze on a Tuesday. On Thursday evening, he's taking me out to dinner at a local restaurant. So some people ask, if you're 80 or over, can you still have the Minimaze? And the answer is absolutely you can. He's right here now on this picture, 2 days, 48 hours after a Minimaze. And we had dinner at a local restaurant, and then on Saturday or Sunday, he flew back to Kentucky. Youngest patient, 15 years old. Oldest patient, 90 years old. And in some patients, as I mentioned, if the whole Minimaze doesn't look like the best solution, we can still get people off blood thinners and decrease the risk of stroke by closing that appendage. Another frequent question is, what if I've already had a stroke? Well, I saw 2 patients like that this week. They had AFib strokes, they've recovered, and they're absolutely candidates for the Minimaze procedure. And the question then comes up, well, if I've had a stroke, I'm on blood thinners, if I have the Minimaze, can I then get off the blood thinners? Simple answer, yes, you can. Even though you've had a stroke, if it was an AFib stroke and we close the appendage, you can get off blood thinners, yes. Let's take another question for Kurt. Kurt, has your family or friends noticed a change since your procedure? That's a loaded question.
Yeah, I mean, prior to the procedure, there was some weird things happening. I would go upstairs and be out of breath, and I just didn't have the energy, and was lethargic, probably grumpy. And so, those were things I didn't really understand were related to AFib, but obviously they were. And, post the procedure, I have been, much more energetic. Like I said, I'm feel like I'm, back, before 50. I mean, I'm more athletic now in the last 2 or 3 years, than I was the prior 4 or 5. And, I'm not so I don't feel as lethargic. I don't feel out of energy. I mean, I'd say they would come up and said, hey, Dad or Kurt, we can see the difference, but there's no question that there's a difference in the quality of my life and the outcomes and so forth since the procedure.
That question brings up sort of an epiphany that I had several years ago. Patients were coming back after Minimaze and saying, Doc, I feel better than I have in 6-7 years. And I go, well, that's great. And I thought, can we attribute all that to getting back in rhythm? And I finally realized the answer is probably no. The answer is 2 parts. One is it's getting back in rhythm. The second part is getting off medication. And here's what typically happens. It may not have happened to you since you were completely out of rhythm, but it's very typical for patients to see the physician, be diagnosed with AFib, started on medication, patient comes back a few months later, still breaking through with AFib. The first thing that's done, increase the medication, right? You just need more. Several months pass, still not getting there, increase the medication. And there's an old saying you can about the frog. If you throw a frog in boiling water, the frog will jump out. But if you put a frog in tepid water, in other words, just kind of warm water, and slowly turn up the heat, you'll cook them. And I think a lot of patients with AFib are being cooked very slowly by dialing up the medication, doubling it. I see patients who come in and they're on a big dose of beta blocker, atenolol, metoprolol. They're on a big dose of amiodarone or flecainide. By the time they get to lunchtime, they're done with the day. They're on the couch. So the epiphany I had was, yes, getting back in rhythm makes a big difference, but probably 50% of it is getting off some of these medications. That's what also really makes you feel better. Now, in your case, I don't recall if you were on a lot or not. Maybe not.
No, I had taken the beta blockers and I was on blood thinners, prior to that, but I would suggest that most of my transformation is really just around getting back in rhythm and feeling confident that I was back in rhythm. And when you feel like you have AFib, you feel like, oh, I can't do this and that, and you feel sort of restricted and constrained. You don't really feel free to pursue things you were doing before or want to do, or you feel concerned about it. So I don't feel like I have any of those. I feel completely unconstrained as it relates to my health.
I'm glad you brought that up. That's a point that needs to be made. It's human nature to try to figure out what your problem is and find your triggers. There's a lot written about triggers. We did a study back in 2007 when I was teaching at University of Cincinnati, and we had patients with AFib keep a diary for a week, and they were also wearing a monitor. And they were told to write down whenever they thought they had an episode. These are people who weren't out all the time like you. To write down when they thought they had an episode and how long it lasted. But we knew exactly what their rhythm was every day, 24 hours a day. There was hardly any correlation. There were lots of times when people said, I think I'm out of rhythm now, and they weren't. There were lots of times when they said, I think I'm in rhythm, and they were out of rhythm. So, but we're always trying to think of these triggers, and a common question I'm asked by a patient is, after the Minimaze, can I have a cup of coffee because I've been avoiding it? Or can I have a chocolate bar? Or can I run? I mean, you name it. Somebody said that's their trigger. It could be a cold drink. And I tell them the whole idea of doing this is so you can enjoy what you want to in life. So if you want to have a glass of wine or you want to have a cup of coffee, you can do it. And some patients even tell me that after the Minimaze, they don't have AFib anymore. They do one of these things that used to trigger their AFib, and they kind of feel like it's going to happen, but it doesn't happen. Again, I think this points to this nerve origin of AFib as opposed to a heart muscle origin of the AFib. And some patients tell me they get upset stomach and then they go into AFib. It's the same nerve that goes to the pulmonary veins that goes to your stomach, the vagus nerve. And other people tell me that after the Minimaze, the stomach problems go away too. It's the same nerve. So I think this whole thing of triggers is interesting, but boy, is it hard to sort out. And a lot of times what you think is your trigger, it may be, but it also may not be. Does that make sense to you?
It makes sense to me. I was in permanent. I don't know what my trigger was, but I mean, before when it was like, oh, I can't drink coffee or drink alcohol and all that stuff, it was like, oh man, I'm going to be on blood thinners. I mean, I love coffee. I can't drink. I mean, like there's all these things like for the next 30 years, going to kind of, suck for lack of a better term. And it just, I just didn't want to go pursue that. So now I don't, like I said, I don't feel any constraints. I feel like a completely healthy, active, person. So
I think
it's not my thought process. To tell you the truth, I don't feel like an AFib patient. I feel like I never had it, right? It's so far in my rearview mirror, I don't think about it.
And that's the key is to say to patients and ultimately really physicians that there is hope for AFib. You don't have to live with it the rest of your life. And if you have that hope and you can realize that, then you can be happy again. Now, I got another question here. We're getting close to the end of the hour, but let's take one more question, Kurt. And this one, probably I'll have to answer part of it. Does diet or genetics attribute to AFib, and what are the causes? Well, first of all, if we figure this out, we'll get the Nobel Prize for medicine. But as I've espoused, I believe, and this wasn't my original idea, I worked with Sonny Jackman, University of Oklahoma, Ben Sherlog, who did a lot of work in this area of the vagal nerves causing AFib. And that's where I got started. And I am convinced that most people who have AFib have nothing wrong with their heart. They have a nervous imbalance, an autonomic nervous imbalance that predisposes them to go into AFib. And these nerves are right around the pulmonary veins, but they're on the outside of the pulmonary veins. You can't get there from the inside of the heart. But with the procedure that I do, you see them, you can get to them right away, can test them and ablate them. There have been many studies done in animals where if you inject alcohol into these nerves around the heart, the animal will stop the AFib like this. Boom. It's clear. So I think the nervous explanation, the autonomic or the vagal AFib, is the key to understanding AFib. Now, do genetics attribute to AFib? Yes, that's for sure too. And I think someday we'll know exactly what your chances are of going into AFib if you have a certain genetic profile. I mean, if it was all about coffee, well, everybody who drank coffee would go in AFib, but they don't. It'd be really bad for Starbucks. So there's a lot more to it. So there's the old question of nature versus nurture, which means how much of it is my genes and how much of it is my environment. And in many cases, the answer is a little bit of both. So you may have a genetic predisposition to it. I see a lot of people that have multiple family members with AFib, but I see people where they're the only member in their family that has AFib. Genetics probably plays a role, and it may be, you may improve your chances of going into AFib if you're very overweight or you have sleep apnea, and there are several other things that contribute to it. But there are many people that drink heavily and never have AFib. There are people that are massively overweight and never have AFib. So it's probably a little bit of each. And maybe one last question for you, just out of curiosity. Have you checked to see if you have any family history of AFib, Kurt?
Yeah, I do. My mom has AFib, so she's on blood thinners for AFib. I think my dad, no, it was my mom definitely has AFib. It's at this point she has some other medical problems, so she's probably not going to be a candidate. She has cancer as well, so she's struggling on a few things. But there is some genetic history for me for AFib. So I do think, I don't know much, but I kind of imagine genetics probably has something to do with it.
Yeah, that's right.
Because I mean, I'm 6'5", 195. I'm in perfectly good shape. So it wouldn't be natural for none of the conditions you articulated there would apply to me. And I had a bad case of AFib.
Yeah, yeah. Well, we will put this webcast on DeBakey CV Education. For those of you in the audience, you're welcome to view it again. As I mentioned, next month we're going to have a discussion with someone who had AFib 14 years ago and has been AFib free for 14 years. Kurt, if anybody has a question after this for you, are you open to them emailing you or anything like that? Is that okay?
Yeah, that'd be fine. You want me to? Should I give you my email here online,
Yeah, that's up to you. It's your email, and you may get it. You may be able to help a few people.
No, I'd be happy to. I just want to close on this thing, and then I'll provide my email address, which is, I said in the beginning, I cannot provide this audience a more clear recommendation or a more clear endorsement than I can provide you to Dr. Wolf's procedure and to Dr. Wolf to treat you for AFib. I mean, my outcome my experience, the doctor-patient interaction, the bedside manner. It was all the best treatment I've had in my life. I mean, I'm just telling you, that's just facts. So if you are wondering which direction to go, I would just give you my strongest endorsement, to work with Dr. Wolf. That said, I'd be happy to answer any questions. So my email address is KUELZ, so it's my first initial and last name, @gmail.com. If I can help anybody out there, I would be thrilled to do it. I feel blessed, and I'd like to return that blessing to others. And so let me know if I can help you.
Kurt, I want to thank you very much. For further information, go to wolfminimaze.com, wolfminimaze.com. I'm always helpful to listen to your story if you have AFib. We do consultations. A lot of them are online these days or video conferences, but I'm always willing to look at anybody's situation. If I think I can help you, I'll say so. If I don't think I can help you, I'll tell you that. Kurt, thanks a lot for sort of paying it back. I really appreciate it. On behalf of all those people out there with AFib, a big thank you. I hope you have a pleasant rest of the week. And when you get up courage to travel again, we'll put another link in for you, okay?
Okay, I'll be happy to do that.
All right. All right. Ladies and gentlemen, thank you for watching and listening to DeBakey CV Live. Until next month, have a safe interval between Thanksgiving and Christmas. Take care.